So objective-wise, we're going to outline the recommended screening prior to initiating clozapine therapy. We're going to list the requirements and some information directly from the REMS programs. And we're going to develop some recommendations for both initial therapy as well as interrupted therapy, both for monitoring as well as for dosing, because there are some patient-specific considerations there. All of the information that, with the exception of one of the first slides, all of the rest of the information did come right from the Clozapine REMS site, which is there, and most of their materials I have asked Jamie to attach, in addition to the slides for you to review. They're also available online, but I just figured it'd be easier to have it all together. So the logistics of clozapine prescribing. So once you've identified a candidate, so clozapine candidates would be patients who have failed at least 2 adequate trials of antipsychotic medication, maybe patients that have persistent symptoms of hostility or violent behaviors, or marked and persistent suicidal thoughts and behaviors. So once we have those candidates, we're really going to focus on next steps. So the next steps start immediately with the Clozapine REM program. So the Clozapine REM program is the Risk Evaluation and Mitigation Strategy program. So originally, each manufacturer of a clozapine product had its own registry to be able to monitor specifically the white blood cell counts for the risk of agranulocytosis for patients, but they were not necessarily linked or not clearly and consistently linked. There were modifications that were made to this program, and that website right there is where all of the remainder of the information has come from. So the Clozapine REMS program is one system for any clozapine product that you're going to use. So this could be the tablets, it could be the orally disintegrating tablets, it could be the suspension. For any clozapine product, regardless of manufacturer, everything's going to go to this one system. It did have a little bit of bumps and bruises as it was getting lifted off the ground, but most of the logistical challenges should have been ironed out by now. It allows for, we're going to talk about the 3 main participants that are really captured within the REMS program, but I felt that it was important that there is a delegation for a prescriber designee certification. So for individuals who are prescribers, there could be someone within the office that has a prescriber designee certification that can help with some of the reporting and enrollment functions that are required. They can do this under the guise of a prescriber. We're going to focus for the remainder of the time on the requirements of the prescribers. So there are 3 buckets of people that the Clozapine REM program provides requirements for. The first is the prescriber. So the requirements of the prescriber are to certify in the REMS program to prescribe. They'll enroll the patients into the Clozapine REMS program prior to starting them on clozapine, and it's also the reporting mechanism for the ANC for every prescription of clozapine. The pharmacy, this pertains to both inpatient and outpatient pharmacy. They have to be certified in the REMS program, so patients can't go to any pharmacy and get clozapine. There may be a handful of pharmacies that I would say most of them do tend to be registered and certified with the REMS program, but there may be some exceptions. Their responsibility is to verify that the prescriber is certified and that the patient is enrolled prior to dispensing any clozapine. So when a patient is initially enrolled, the prescriber needs to be certified, the patient needs to be active, there needs to be a A1C value within the last 7 days. Then the REMS program actually provides the pharmacy with an electronic code. It's called the PDA, the pre-dispense authorization. And that essentially gives the green light to allow the patient to get the clozapine for the first time. The patient, their end of the bargain is they need to agree to be enrolled within the REMS program, and then they need to comply with the testing requirements. So if they are not getting their blood test, the pharmacy will not be releasing the medication. So it's important that they understand kind of the set of steps that go into this, especially when they first start treatment and maybe adjusting their doses. they'll only get a week of medication at a time because that's all the pharmacy would be allowed to release. And it needs to be that they get their blood done before they're able to get their medications. And if those results aren't back yet, they may not release their medications at all. And that is for safety reasons, to ensure that the patient does not have a low ANC. So for the program itself, the patients, there are enrollment forms, both for the prescriber as well as for the patient. And one of the first steps that's required is that there is the provision and review of educational materials. So the materials that they've developed, it's a 4 or 5 page booklet, and it's called A Guide for Patients and Caregivers. One of the barriers or challenges that's come up with the use of clozapine has been that in some instances, it's been referred to as a drug of last resort. When you've failed everything else, when you're refractory to treatment, that may not be the best way to frame the use of clozapine. It is difficult to use, and there are definitely some risks associated with it, but the benefit that we see in patients that haven't responded to other antipsychotics really tends to outweigh that potential risk. So this guide helps to describe why clozapine would be used and what some of the risks and interesting, unique requirements are for the use of this medication. Now, the medication guide could be provided by the prescriber's designee, another individual within the office. It may be reviewed by the prescriber, it may be reviewed by the pharmacist, but it's really important that the patient and whoever their support system has a good understanding of the benefits and risks of undergoing this medication. Because it's a longer titration, it's going to take a little while to get up to therapeutic, it'll take a couple weeks to get to therapeutic doses, unlike some of the medications where you can start and be at a therapeutic dose right away. And those monitoring requirements really are going to require some dedication to this regimen. So the initial monitoring that's required, we're going to focus primarily on the complete blood cell count with differential. Most of it will be CBC throughout the rest of the slides just to save room. But the main thing that we're looking for is the absolute neutrophil count, so the ANC. This must be done before patients are prescribed the clozapine. Now, based on the results, those baseline results before a patient is exposed, if there are patients that have lower neutrophil counts, then 2 baseline values are requested because they may fall into the category called the benign ethnic neutropenia patients, or the BEN patients. So these patients tend to have a baseline neutrophil count that's lower than the general population, but their overall risk for developing agranulocytosis is not greater than other patients. But by giving these new requirements in this new population, it allows us to utilize clozapine in a patient population that may not have been candidates for it before. Other monitoring that should be done is the metabolic monitoring. So looking at personal and family medical history, their weight, height, body mass index, waist circumference, blood pressure, fasting glucose and lipid panel, as well as a movement evaluation. So looking for any extrapyramidal symptoms. The largest concern and the main focus for the remainder of the presentation really is going to be on the neutrophil count monitoring, because this is where some of those logistics come into play. The greatest risk for the patient developing agranulocytosis tends to be within the first 18 weeks of therapy, and it's not found to be dose dependent. But as you'll see, we do continue the monitoring in patients for as long as they are on clozapine. So what needs to be done logistically? So patients really need to be set up with a lab that's going to be convenient for them to get to, especially if maybe they need to do it very early in the morning or later in the afternoon because of work or school schedules, where they could do that on a consistent basis, because it's required that they get their blood drawn every week for the first 6 months of therapy. Now, as long as patients remain in their normal ranges, then after 6 months, between 6 and 12 months, they can extend that to having their blood work drawn every 2 weeks. After that first year of therapy, if their levels have been normal, then it can be drawn just once a month. Now the normal ranges, so there are 2 columns on each of these monitoring slides. The one on the left-hand side is the normal range for the general population. So they're looking for ANC values above 1,500. For those patients that may be a little bit lower, but are lower at baseline before they're even exposed to the clozapine, then their ANC values, as long as they're above 1,000. And those would be considered their normal ranges, and that's what they need to stay in to have the normal monitoring requirements. So assuming things are going smoothly, the dosing that we would want to start with, it's recommended to start with 12.5 milligrams either once or twice a day. This can then be increased by 25 to 50 milligrams each day, depending on how well the patient tolerates it. So sedation, as well as orthostatic hypotension and syncope, these tend to be some of the episodes that make it a little difficult to titrate therapy in some patients. It takes them some time to be able to tolerate it. Patients do not have to be inpatient to be initiated on clozapine. However, outpatient titration may be a little bit slower, just to ensure that the patients are able to appropriately tolerate their medication. The goal really would be by the end of 2 weeks to be at a target dose of about 300 to 450 milligrams, so maybe 150 twice a day. In some cases, patients may find that they're very sleepy after they take the medication. So in some instances, you may see that there's a larger dose, a larger milligram amount dose given at bedtime as opposed to in the morning. And that's a way to try to individualize therapy so that patients can still be functional during the day. Further dose increases can be made. They can increase by no more than 100 milligrams a day, and the recommended maximum is 900 milligrams a day. Now, there are some reports in patients who are smokers. So the aromatic hydrocarbons in cigarette smoke can induce the cytochrome P451A2 enzyme. What that means is it can metabolize clozapine a lot faster. So there have been some reports of patients on doses larger than 900 milligrams, but that was after the patient was on a 900 milligram dose. They evaluated some of the clozapine serum concentrations and found that they really were lower than what they had anticipated, and they did feel that they could increase the dose a little bit. But again, further consent and discussion and education about the risks versus benefits was important to be documented in those cases. So the hope would be that patients do not have trouble with their ANC values. In some cases, their ANC values may decrease. So what happens when that occurs? The Clozapine REMS program actually has a 1-page chart that walks you through all of the different degrees of neutropenia. For mild neutropenia, it's recommended to continue treatment, that it's not, treatment does not have to be interrupted at this point. So mild neutropenia values are between 1,000 and 1,499. So the normal value for the general population was over 1,500. So this would fall just underneath that. But this is still the normal value for the BEN population. So their monitoring requirements for blood work does not change. So their baseline may have been as low as 1,000, so they can continue on their regular blood draw monitoring. For the general population, if they do fall between the 1,000 and 1,499, it's recommended that their blood draw be increased to 3 times a week until their ANC values get back above the 1,500. Once it's there, they could go back. So if they were once monthly and they drop to 1,300, you check their CBC 3 times a week until they get back over 1,500, then it could go back to once a month. The first time there is a low value, it is recommended that that value be redrawn just to ensure that there wasn't a lab error, that it wasn't just an anomaly, that it is confirmed that the ANC is below that 1,500 mark. But we do not have to interrupt therapy at this point. If it progresses even further down to moderate neutropenia, these are ANC values between 500 and 999, so just under that 1,000 mark. In both cases, it's recommended to get a hematology consult. For patients in the general population, they do recommend interrupting therapy until the ANC gets back above 1,000. They want daily CBCs until the ANC is over 1,000, then 3 times a week, and then they'll do it once a week when it's over 1,500 for at least the next month. So they'll slowly step them back from daily to 3 times a week to weekly, and then they can go back to what their prior frequency was. For the BEN population, they can continue treatments. They do recommend the hematology consult, and they recommend increasing the frequency to 3 times a week. Now, their baseline value, their threshold value to get back to the other frequency would be either 1,000 or what their baseline had been. So, because to be diagnosed with BEN, it's 1,000 or higher, that 1,000 really is the threshold that you're looking for. So definitely interrupting therapy for patients in the general population. You can continue therapy, but you need to increase your testing requirements for patients in the BEN population, and then slowly move back with weekly checks for a month, and then they can go back to their prior monitoring frequency. So it's not that it can't be used, but we just need to be a little bit more diligent in these patients. For patients that progress to severe neutropenia with their ANC counts less than 500, a hematology consultation is recommended, and they recommend interrupting therapy at this point. Increased frequency of monitoring daily until the ANC is over 1,000 in the general population or over 500 in the BEN population, then 3 times weekly until they get back above either 1,500 or the 1,000 milligram mark. Previously, there had been some suggestion not to re-challenge these patients. These patients can be re-challenged with clozapine after their values are back above either the 1,500 milligram mark or the 1,500 mark or the 1,000 mark of their ANC. But there needs to be an authorization to continue treatment. So some type of treatment rationale that describes why the benefits of being on clozapine outweigh the risks. So the REM system will automatically change the patient's category from an active patient to either an interrupted patient or a discontinued patient. So the prescriber would have to go in and move them back to active and provide that treatment rationale that explains why those benefits outweigh the risks. In those cases where patients did need some type of interruption in their therapy, or if we need to discontinue therapy, we will change the monitoring just a little bit. So for patients in the general population who stopped therapy because they had the moderate neutropenia, we're going to do daily checks until it's over the 1,000, then 3 times a week till it's over the 1,500. If they have severe neutropenia, again, daily until it's over 1,000, 3 times weekly till it's over 1,500. So they essentially want them to continue to monitor until they get back to the 1,500 mark of their ANC. For those BEN patients, daily checks until the ANC is above 500, then 3 times weekly until that ANC is at least above 1,000. So continue checking. We need to keep doing those blood draws, even if the patient is off of their clozapine, especially if they develop neutropenia. Now, if the patient stops the clozapine due to another reason, so maybe it's another side effect, maybe they're non-adherent, maybe they ran out of medication, it is recommended we continue to check with what their previous monitoring frequency had been, so that we do at least do one more blood draw to ensure that their ANC values are normal, so above either the 1,500 mark or the 1,000 mark. If the patients have stopped the clozapine for another reason, there's one other monitoring piece that needs to be done. So after they stop clozapine for the next 2 weeks, it's important that they're monitored for any fever. If they develop a fever over 101.3, then it is recommended that another CBC be drawn just to check their ANC value. The reason for this, the half-life for clozapine is estimated at 12 hours, but the range in adults is between 4 and 66 hours, which means it can take up to 2 full weeks for the body to really fully clear the clozapine, so it may still continue to have some effects on the neutrophil count. And that's why if they do spike a fever, we want to make sure that their neutrophils are not compromised. So in addition to their dosing, in addition to their monitoring, dosing changes. So if a patient's off of clozapine therapy for whatever reason, for 2 days or more, it is recommended to restart at the very beginning. Now, there are some individual prescribers who have had patients that are on higher doses, 600, 700 milligrams, that have needed to interrupt therapy briefly because of ANC readings that may not have started at the 12.5 twice a day and titrated up. They may have started at a lower dose and slowly moved them back up. That has been reported in clinical practice. There are no recommendations regarding that in the evidence. So all of the package inserts recommend discontinued for 2 days or more to start back at the beginning. The reason for that retitration is because of the risk of hypotension, bradycardia, and syncopal episodes, so that the patient may be a little bit more sensitive to those side effects. So starting back at the low dose and titrating them back up would be a way to minimize those potential adverse effects. So this is what the main page of the Clozapine REMS program looks like. All of the information that was included there is to be found on those pages, along with all of the package inserts for each of the clozapine products. So they have links directly to them that you can find right off these pages as well. So it is a tremendous resource for you to use, and a number of those attachments will be included with the slides. And then that, I think, is it.